type of ankle fractures can involve the proximal fibula as well. And so I often will just check that area. The syndesmosis, if there's an obvious fracture, you don't want to be squeezing, but for ruling out those or ruling in those high ankle sprains, it is something that you want to palpate along between the tib fib, or a gentle squeeze on the tib fib, or at the distal aspect of the tib fib for those ligaments that have attachments there for that diagnosis there. And then I also palpate the medial and lateral malleolus and the ligaments that are adjacent to there. And then palpating over that anterior ankle to make sure that there's, you're looking for talar pain, talar fractures, and an often forgotten area is the anterior process of the calcaneus that I will have a picture of later on here. But just a kind of on clinical exam, it's generally in this vicinity here that you want to touch on that area, because it's often an area that doesn't show up very well on x-rays. There's overlap in that area. And so it doesn't always show up very well, but it's one that can cause some chronic pain issues. Then the peroneal tendons on the lateral aspect, your medial tendons, including your posterior tibial tendon, and the fifth metatarsal base and Achilles tendon. So I didn't include as much of the anterior tendons and structures, soft tissue-wise, just with the nature of the type of injury that I'm focusing on here. Just kind of some basic anatomy. This is the medial aspect here. So you see the ligamentous structures that are coming down here, and then just some of the other ligamentous areas that you see. And then this just includes some of the tendons coming in here. And the posterior tibial tendon is one that would be more commonly injured than some of the other medial structures. But you can also see the tibialis anterior coming down here for where that attaches to the foot. And so these are just structures to remind and remember that can also get injured with these type of described ankle sprains. And then on your lateral aspect, the peroneal tendons are very often injured with the chief complaint of I sprained my ankle, tears, chronic synovitis, and at times rupture as well. So really an area you want to palpate and take a closer look at. And then this is just kind of the chief complaint or area, the lateral ankle sprain. So you have your the lateral collateral ligaments here that I included, but also include the peroneal tendons that you really want to look at of these type of injuries, because often that can be where the symptoms really are, is the peroneal tendons, and that's something that can they can rupture a tendon and still walk on it, but it becomes a very chronic pain. They can get some retraction of those tendons to cause a lot of chronic instability of their ankle as well. Again, with the ankle sprain of even a ligament injury, you can get chronic instability, comes more chronic problems. Post-traumatic arthritis, if they get a lot of instability, can occur later in life. And so just you're looking for pain over the ligaments, tendons, the ecchymosis aspect, edema, and the instability, which typically is going to be more later on. It's not a fair assessment acutely, but that would be more of your chronic presentation. And of course, you want to have x-rays still as far as evaluating for something. You can have an avulsion fracture that would still be at like the ligamentous attachment, but can actually be an avulsion fracture. And then just general treatment. I didn't focus as much on the specifics of treatment, but just kept more for the diagnosis standpoint, things to be looking for. But, you know, ankle sprains, if they get into that moderate to severe sprain, they often need some immobilization. And then rehabilitation is important as well for these to try to prevent some of that chronic instability when the timing is appropriate, and ruling out any fractures or tendon tears. Surgical is something, again, more for the chronic instability generally. There are sometimes acute procedures that you can do, but generally this becomes more of the chronic issue that we try to catch before it becomes the chronic issue. And you have to kind of have your radar up. If a patient comes in with a real moderate to severe edematous, ecchymotic foot or ankle, certainly can still be a sprain, but you really want to have your radar up that something else is more can be going on. And initial x-rays are not always definitive, which sometimes things are a little late to show up, especially with all the overlap on the foot and ankle. The sinus tarsitis is a structure on the lateral aspect of the ankle, just anterior to the distal fibula. And it's often an area that kind of has residual symptoms. And it also can even be after they've gone through some rehabilitation. It can be an area that is residual It's very pinpoint tender. It can also be a little bit biomechanical for patients that have a real flat foot and pronate on that foot significantly. So it can also be a chronic presentation, but can be quite painful, and it's often aggravated. That uneven ground can have some instability descriptors to it. Conservatively, there are things we do, often injections, orthotics, those types of things. Rarely do there's surgical treatments for it, but we rarely have to do those. So, but they are out there. And then your pocket of area that you want to kind of check for is this little area right here is the entry, or that sinus tarsi area. And then your ankle fractures. Some ankle fractures are very obvious. Others can be more subtle. There can also be stress fractures of the in the ankle that may not necessarily show up on X-ray. So just your general bones, obviously, that can be involved. Medial lateral malleolus, the posterior malleolus, and then your syndesmosis, you're checking for instability of that. And then your talus, Talar fractures, or your osteochondral defects, or your OCDs, that can be sometimes not apparent on X-ray very well. So of course you rely on your exam, X-rays. Sometimes we need to get further testing. One thing I'll mention is some of these diagnoses do need some further higher level of imaging. Other times you treat more by diagnosis, and generally those are something at times we differentiate what needs to be done for the type of fracture it is. So there's conservative treatment for ankle fractures for your non-displaced fractures, or this what starts as a stress injury. But very important that the majority of these need to be non-weight bearing. Oftentimes they need casting because some of these fractures can be unstable, and what may start as a non-surgical fracture, if it's not treated appropriately or not offloaded enough, can become a surgical fracture if there's true instability of it. So it is something you have to be cautious with as far as treatment goes, but very important that people are getting off these for most of these fractures. And then ankle fracture, obviously sometimes need to put them back together as well, plates and screws. For the osteochondral defect, sometimes they need scoping or further treatment that way as well. And just a couple pictures for you. This is one of those more obvious fractures where there is a fibular fracture here, and on the lateral, you can see here, might be a little posterior malleolar involvement here, but not displaced. But you also look at this medial gutter here, and you can see that there's obvious widening of the gutter as well. So things that you want to be looking for, because this typically becomes more of a surgical fracture. And just seeing here, by reducing that lateral aspect, our gutter is nice and reduced as well, but sometimes fixation's needed here or across these bones as well. And then you can have an isolated medial malleolar fracture where the others are not involved. Sometimes surgical, sometimes not, but you can also have stress injuries again in this area that may be less obvious. And then your posterior malleolar fractures, you're typically only going to see these on a lateral view. Sometimes you can see a hint of it on the AP view, but it's less descriptive or harder to see. But you're going to see your kind of linear line coming across here, and that's the posterior malleolar fracture, which tends to be pretty subtle in presentation. So again, you're relying on your exam to really be looking for that on X-ray. And then the high ankle sprain, that's usually injury to the syndesmosis or the ligaments involved with that. So something, again, this is something that can lead to some more of the chronic instability pain, chronic arthritis, those types of more ongoing issues that have a harder time improving. So again, these really have to get off of them. Sometimes, again, casting or boots initially for that area to heal. But these are the normals as far as a radiographic evaluation. So in summary, I mean, you're really looking at that medial gutter that I just showed you on the previous X-ray, if that looks widened. The overlap between your tibia and fibula, you're seeing if that looks like there's a gap between there. And then there's a small clear space that it's a very small and sometimes hard to measure, but just for all-inclusive sake. But you're really looking for just that widening of that medial gutter, the widening or spacing that shouldn't really be there. And that can indicate that high ankle sprain or syndesmotic injury. And so again, there's conservative options. Sometimes if it's a latent, meaning there's not obvious instability or obvious gapping, Then sometimes crutches, casting, that type of thing. If there is obvious spacing between there, a lot of times you do need to go there and put a screw or a fixation across that syndesmosis to stabilize it. And this is actually, I believe it was a high school football player that the syndesmotic injury went undiagnosed. And you can see here, I got him kind of late, but you can see that they're starting to get this ossification between here. So this was probably already a couple months out from his injury, and he now has this forming. So with time and aging, I mean, he could develop a synostosis between these, a bony union between these, which again can be chronically painful and things like that. So subtle things, and it's but one that could cause some troubles down the road. Then your osteochondral defects, these often don't show up on x-ray. You have a posterior medial lesion generally and an anterior lateral lesion. Those are just kind of the most common descriptors. You can have them other places, but those are generally the most common. And a lot of times you can't make these things hurt when you're trying to examine them. You're poking around trying to make it hurt, and you can't really hurt these at times. And so patients may complain again of instability or kind of some grinding or catching in the joint, but you can't always make it hurt. You can't always elicit it on clinical exam. Sometimes it's an acute injury, sometimes it's old that'll just show up later, but that's something just to kind of look for as well. And then again, treatment. If you're getting these acutely, they do respond typically fairly well to the casting and crutches. If you get them later and they're symptomatic, then often they need arthroscopy. The real large ones, sometimes you're going to grafting that area. They have some cartilage implantation that they can do as well. Some different kits that we have that are pretty interesting, but just something to keep in mind as well. And then this is one of the, I would say, more subtle ones. It's just this lucency you see on the talus here. They can be more involved where it looks like this is detached from the area, but at times they can be pretty subtle. And then moving on to your talar fractures. This one is a nice example of a little bit of not relying on the initial x-ray. A lot of times these things are delayed to show up. So this x-ray initially looks more like an avulsion type talar fractures, this little piece that breaks off where there's a ligamentous attachment. And so those typically, we boot them, we do immobilize them and treat them. But this is 2 weeks after the patient's injury that she presented to my office in somewhat severe pain. So she was casted and made non-weight bearing. And then 2 weeks after this is when the repeat x-ray was done. Now you can start to see that she actually has kind of that talar head, talar neck fracture that's starting to come down here, being this real light, fine line here. And then another 2 weeks down the road, now you can see that it is healing. But most of the time, you're not going to see these start healing until you get the patient off their foot and immobilized, or you're still having that motion across the fracture, and the fracture can't start that healing process. So oftentimes, until it gets off of it, this will be delayed as far as seeing these healing. And the one thing about this bone, or many things about this bone, but one thing is that not in this area, but other areas of that, subtle injuries can cause an avascular necrosis when you start getting more of these severe talar neck fractures, or sometimes the talar body fractures. So sometimes the anatomic location of where the actual bone fractured can set them up for more severe complications down the road. This one is, I would say, a little bit more obvious. My x-ray is a little blurry, I apologize. But this area here is where it's a little more obvious on x-ray that there's something going on that shouldn't be here. And then with the CT scan, you can see that fracture coming through there that's more pronounced. And this is just kind of one of those ways that we can fix this type of fractures, a couple of screws through that. So another important topic is any tendon tears. Or having that radar out for ruptures. The posterior tibial tendon, you can see chronic tears in this tendon frequently with patients with severe flat feet or a progressive flat foot. You will see these as a more chronic tear, probably more oftenly than an acute tear, but certainly something to be aware of. Again, I didn't include the anterior tendons as much because they're usually a little less likely involved with the type of trauma that I'm talking about. But your peroneal tendons, again, really important to make sure you're palpating those and seeing if there's a lot of pain or synovitis through that area. and you want to evaluate the strength of them. If there's weakness, which almost always there is initially after injury because of pain, but that's something you want to kind of keep checking for. If you get the patient really quick afterwards, you'll sometimes see a retraction of the tendon. You can actually see a little balled up area if you get them right after rupture, but once the swelling sets in, you're not going to see that very well. But as the peroneal tendons, especially your Achilles tendon, obviously there's a Thompson squeeze test where you're squeezing the back of that calf to see if you're getting plantar flexion. One thing that you have to keep in mind is that there's deeper muscles that if you squeeze too deep, you're going to get plantar flexion because those other muscles will kick in. And so it may be kind of a false negative that there is an actual rupture or at least a partial tear there. So it is important to compare to the contralateral side to see if there's a difference, but also making sure that you're not squeezing deeper because then you will get some plantar flexion out of there. But some of these tendon tears, especially if patients walk on them too long, then you're getting more retraction and it's a little harder to kind of pull them back together at times. This is a tear in the posterior tibial tendon, but you can see how it's thickened through here. You see kind of those white lines going through there. And that's typically a decent-sized longitudinal tear when you're looking at them intraoperatively that needs to be repaired. There are times when a tendon gets beyond repair if that tear has been present too long, and then sometimes patients will require a tendon transfer to reinforce the damaged tendon. This is a patient that fairly interesting, but this is a peroneal tendon rupture right here. So this is a tendon here that should come and follow this one here. It should come down here and follow all the way down here, and it has a very abrupt stop. So that was probably one of the most pronounced ruptures that I have seen, but she also walked on it for about a year after it happened. So she had just extremely retracted tendons. The other peroneal tendon, there's two. The other one was severely damaged as well because they'd been taking up the force for so long. And so she actually ended up having to have her subtalar joint fused because it was so unstable, it was beyond repair. And so that's just something too that she just kind of complained of this kind of chronic pain, chronic instability. And so about a year after injuries when I saw her, and so again, this is how much the tendon had retracted. And so when it gets this is again one of the most severe ones, but when it gets to that is kind of beyond repair. And this is a less involved one, but still very inflamed. All the white is that chronic synovitis around there. The tear portion, this was a longitudinal tear. It kind of goes from, whoops, there we go, tracked through about here. So that area where, oh, I pushed a button. That area through here where you have that longitudinal, that thickening of the tendon, that abnormality there, that's more of your longitudinal tear, repairable. But there's a significant amount of inflammatory, as you can see, inflammatory synovitis through there, causing and contributing to the pain. And then this is just an Achilles tendon rupture. This just shows more of a chronic, again, rupture where a patient maybe does it and doesn't realize it. Achilles tendon ruptures, they tend to be pretty painful initially, where they describe that big pop that felt like somebody hit them in the back of the ankle. But if they walk on it for a little while, it's still sore, but it kind of, the pain intensity more often than not will decrease. So they just say it feels weak or it feels abnormal. They don't have quite the intensity of the pain as the initial injury. So it's a little bit of a false hope that it's getting better. But this is the amount of gapping between the Achilles tendon ends here. So here's one end and here's the other end. And so that becomes more of your, again, your chronic repair, where you usually need some other tendons to help to close that gap. And then just to move on down the line, the calcaneus also has lots of anatomy within itself. That anterior process is what I mentioned previously, kind of at the front of the bone, that there's a ligament that attaches to that area that often goes within kind of that inversion type injury that you can fracture that, and with the overlap in that area, it's difficult to see. The tuber fractures, that plantar part of the bone, you know, if somebody kind of jumps down from a height and has that real impact, lands on their heels type thing, that can fracture. And one that isn't very obvious on plain films either, that it'll show up more like a stress fracture, but very painful to walk on. And then the posterior avulsion fracture, a little less common, but still, and that one's a little more obvious as well. Your interarticular fractures are typically your classic fall from a height, usually putting up Christmas lights or roofing, and they fall and they get more of that crush injury to the calcaneus. And then stress fractures that can come more with, a lot of times runners increasing mileage too quickly. And so different types of fractures for this bone. The anterior process, I focus on that one because I think that's one that's often missed just because it's not very obvious. And so just one I'm kind of reinforcing. It's one that if it goes on too long, it's hard to do anything but take the fracture fragment out, which can leave a little instability to the joint. So, but it's one that the radar is usually a little lower on this particular diagnosis. And so you want to kind of really palpate in that area. And you need that high degree of suspicion, that inversion type injury. And there may be a delay in appearance if it shows up on x-ray. Sometimes it does not. And the area right here, and again, it's subtle, but it's this line coming right through here. And that's on this oblique foot film is a lot of times where you're going to see it. You can sometimes see it on the lateral view as well. But these often need the casting and on weight bearing, or they really are very slow to heal. And then same thing on this one. This one might be a little bit more of a chronic, but it looks like there's a little increased density to this area, and that's all you see there. This one's more obvious, but just where that Achilles tendon attaches, it kind of pops off that large bone fragment, and just kind of showing you how it goes back together. This is your more involved, your fall from a height, that interarticular fracture. These are often left with some subtalar joint arthritis that at times needs to be fused in the future. They will typically have some degree of post-traumatic arthritis on there, typically need further support, orthotics, a lot of times a lot of rehab, just to get that strength and mobility back. It's a difficult fracture. But you can see we put a lot of hardware in those too. And then moving down to your midfoot, this is an area too. The navicular is like the talus, where it's a little bit of a sensitive bone. It can be a little higher risk for avascular necrosis or non-union, delayed union, and again, aren't always as obvious. This is a navicular fracture here, and this one started out probably more as a stress fracture where they just had some generalized symptoms for a couple weeks, and then they had a moment where they stepped down wrong and felt that final pop, and so had something kind of brewing in there, didn't think much of it, and then had that final moment. And so the fracture here is this linear line, and this is a very common spot for the like a stress fracture or a navicular injury to be at. You can also get a little bit of an avulsion up here sometimes. There's also an accessory bone that's very common to be there that's not traumatic, and actually she has a little bit of one here. You can see that little there, so sometimes that can be misleading as a fracture. Your Liszt franc fractures, the one on the left is a little bit more obvious in my opinion. It's got more of that lateral shift across the whole complex. You can see these joints aren't lined up here. This one just shows you a little more subtle where the gap is actually right here, but that's about the only involvement. But again, it can lead to more of that chronic pain. And so if they have that high velocity injury, motor vehicle accident, those are a little bit more where you're going to see this type. And then generally stress fractures, but stress metatarsal fractures is something we very commonly see. A lot of times you're going to see it in patients that have that remote history of either running, training for something, triathletes, those type of people that are a little hard on their feet. People can get it just increasing their activity generally. Sometimes around the holidays you'll see even an older patient that's not as active, but they've been on their feet doing more, getting ready for that they will develop these as well, and they're not the athlete per se. But it's not uncommon to see it in that patient population as well. They usually get a little pocket of edema first in the area. As it goes on longer, it'll be more diffuse edema. It often resembles cellulitis, and a lot of people are treated initially for cellulitis because it gets this little dull erythema that forms in the area of the edema. And so a lot of times initially it's kind of misleading that it's a cellulitis, but you really got to palpate. If it's painful over that mid-shaft, that's typically where it's going to be most presenting. Again, the longer it goes on, they get real diffuse generalized pain and edema that it's hard to localize exactly the specific area. And again, for these, anytime you're getting beyond the digits more or less in your hallux, you are looking more at kind of casting or booting than a post-op shoe. A post-op shoe is generally not enough for a metatarsal fracture. The metatarsal fractures, people tend to be more active than what they should, and you can displace them. So again, what starts as a non-surgical fracture can become a surgical fracture. And the other thing is patients don't get pain relief from them. So if they have a lot of pain and swelling and they're placed in a post-op shoe, they usually continue to have a lot of pain with it. This is one that presented about 6 weeks out. So this is their stress fracture here, and this is my first visit with them. And what was treated again in the post-op shoe. But the one thing, and this was at an outside facility, but what you see here is this angulation in the metatarsal that's present. And again, it's subtle, but if you walk on these, and again, people tend to be too active on them. And so this could lead to, again, some chronic troubles as far as pain on the bottom of the foot. The metatarsal head area on the plantar aspect can tend to be more a chronic pain issue, because this metatarsal should be heading in this direction, and it's up here further. And then this is just an example of sometimes how long stress fractures can take to show up on x-ray when you're looking for them. And I don't routinely get MRIs or those higher level of imaging, because it doesn't change my treatment. If I am pretty confident that it's a stress fracture, then I treat it with or follow it with radiographs. But this is the initial x-ray. This patient was a triathlete and was training. And you can see maybe in hindsight a little hint of something here, but most likely you're not going to read that probably as positive there. But here 2 weeks later, you can start to see that very faint stress fracture starting to show up. And then a month, you can see it's getting more dense here as far as the healing goes. And then she's got a nice improved healing here. So just kind of the timing that it can take. Sometimes they are pretty slow to be obvious on x-ray. And then your fifth metatarsal fractures get their own category, very common, different types depending on, again, the location on the bone, whether it's avulsion Jones or kind of your mid-shaft. And just some pictures to reiterate. This is one that, again, the post-op shoe is generally not enough for a fifth metatarsal fracture. People tend to be too active on them. And what starts, again, as a non-displaced fracture can fairly quickly become that displaced fracture, because there's that tendon attachment there that can open that up a little bit. This is another example of one that tend to walk on it again too much. So it starts here and got a little, there's usually a little resorption there for a follow-up x-ray, but this is a little bit more than what it should be. Your Jones fracture is, by definition, your diaphyseal, metaphyseal junction further up here. Again, oftentimes it's a surgical fracture because they have a slow rate of healing without. And then this is the type of surgery that we do for it. And then this just, again, different type of fracture, but these tend to be fairly unstable, and without the immobilization and being off of it can be fairly slow to heal or not heal. This one, it's a little more atypical fracture, but I thought it was interesting just to put in, and just to kind of keep in mind that your peroneal tendon does come down and attach here. So if you get that comminution there and a large retraction there, you want to make sure that the peroneal tendon also didn't get injured with that presentation. And then just this one just shows something that looks fairly benign on x-ray. But what this is a hallux fracture, and the joint basically got impacted. So this is the actual fracture here. But on the lateral view, you can see this is the joint line here. So what should be at this angle is impacted and displaced up. And so this just shows, this was what I took and pinned. So you can kind of see the joint alignment is improved. And then on this lateral view, we have a nice straight joint here. You can still obviously be at risk for post-traumatic arthritis with any joint injury. That can lead to more of that chronic aching and that type of thing. But this will improve the outcome. And I like to say it's not just a toe. Many times we have patients that come in and say, this toe really hurts me. I injured it like 2 weeks ago, but I didn't think there was anything you could do for it. This is one that, again, on AP view, it really doesn't look overly out of place. This is the fracture line here. But if you look at the lateral view, this is the head of the proximal phalanx here, but there's nothing below it because it's sitting completely on top of that residual proximal phalanx. So what looks pretty benign here, getting that other view, you can see that is malaligned. And if it either won't heal in that position or it'll heal poorly in that position. So this is just taking it and pinning that to get the better alignment so it can heal in a more timely and better position. And just a few pearls. These are not all trauma related, but just kind of keep in mind that there's more anatomy to the foot and ankle than just bone. And you want to make sure that the radar's up for some of those injuries that can be become more chronic and bothersome for the patient. The first x-ray is not always definitive. Sometimes it takes some further treatment or repeat x-rays before something will show up. An x-ray should, in most cases, be the first test for injury or concerns for bone infection. That still should be the first x-ray. I don't like to skip that to go to a higher level of imaging because an x-ray can tell you a lot as far as what you're looking for. Bone scans for trauma and infections a lot of times can give us more limited information. It's a generalized scan. So if we're doing anything as far as looking for surgical planning or trying to get that more information as far as treatment goes, a lot of times bone scans aren't as helpful for us. So just something to keep in mind. And these are a little off the trauma, but a lot of times peripheral vascular studies are more helpful than just a straight ABI when you're ordering those. If a patient's diabetic, they have vascular diagnosis, cardiac diagnosis, there's usually going to be some involvement in the digits or further down the limb. So it's often, especially if the patient is symptomatic with those things, it's often more informative as far as what's going on and the level of which it's going on. And then when you are able, and at your clinics, if you can get weight-bearing x-rays, if it's not trauma, if the patient's looking for us to do a surgical consult or things like that, we always will need a weight-bearing x-ray. So that just helps us out, or if they have kind of a chronic pain, again, the weight-bearing x-ray helps because it looks a little better at structure than the non-weight-bearing. Obviously, if it's trauma, you don't want the weight-bearing x-ray. And then oftentimes with the injury, sometimes the patient will often come in with a chief complaint, say my ankle hurts, but it can actually be their foot or vice versa. A lot of times they just lump it all together. So a lot of times when you're thinking about what x-ray you ordered, kind of get that vicinity of exactly where it's at, or order both the foot and ankle when it's trauma, because oftentimes where the patient calls it is not always what the information you need. Neuropathy plays a role in symptoms or lack of. So if they have a peripheral vascular disease or they've had trauma, they're usually going to have a lower level of expression of pain or symptoms of that. So just kind of keep that in mind. And then you want to make sure you're properly fitting boots and cam boots and crutches. We have general recommendations that go with shoe sizing, but you want to make sure you're not letting a patient walk out with their toes hanging over or having it a full size too big, because then it's not properly immobilizing. When you're fitting cam boots, there's tabs on the side. You want to make sure that that ankle's getting in there at a 90-degree angle and pulling those tabs out. That's what helps hold the foot in a stabilized position. If you're leaving those in there, you're going to get a lot of flux across that ankle, and it won't be as stable. And then crutches, again, it's general sizing as far as they tell you how tall they are, but you want to make sure it's still fitting appropriately, that they're not leaning over or not, having to stretch too far. And then just wound clinic reminder, when you're referring patients over there, we each have our own clinic day. So sometimes when they're scheduling, it has to be within a physician for the first appointment. And then and they want to get it with the appropriate physician. So that's just sometimes why it takes a couple of days. And then when you have your wounds, make sure you're keeping in mind swelling and edema really slow down wound healing. And so there's a lot of times some different wrapping and things like that we can do at the wound clinic to kind of help streamline those healing. So I think that is it. If there are any questions at all?
Erin, thanks for a good talk. For the women athletes that have a stress fracture, what do you recommend that they do to prevent recurrent stress fractures?
That's a good point. So oftentimes, one part of it is making sure they're not returning to play too soon, because if that is not completely healed or if they dive back in too quick, they're at risk for re-injuring what they just had, or the metatarsal fractures adjacent to it are at higher risk for stressing them and causing a stress fracture in the adjacent one. So they get one healed and they're right back. So oftentimes it's the guidance as far as return to activity to make sure that's at an appropriate pace. A lot of times I will talk to patients about orthotics as well to get them better supported, making sure shoe gear is appropriate as well to make sure that they're properly supported so they're not causing too much stress and strain.
Erin, I know you didn't cover this, but in the past I'd heard that runners who had chondromalacia would often benefit by orthotics. Is that still in the mainstream thinking, or was that some
As far as what is a specific one that you're referring to, or I mean, generally anything that they have, like if accessory oscles, that type of thing, if that's more what you're referring to, it's yes, when it comes down to biomechanics on functioning or things like that, yes, we still do a lot of orthotics for a lot of these things that I just didn't rely as much on the treatment aspect, more just kind of increasing the awareness. But yeah, a lot of times on these fractures, calcaneal fractures, metatarsal fractures, chronic kind of foot troubles, then yes, often we still do a lot of orthotics.
Yeah, but I was specifically asking for chondromalacia of the patella, runner's
Oh, of the
knee.
patella. Okay, yeah. So
runner's knee.
yes, I mean, still, and again, usually we're looking at kind of the biomechanics all the way down. And if there's like a biomechanical reason that they're getting some of that, yes, we still will address that. Sorry.
You addressed the prevention after stress fractures have already occurred. What advice do you have for people to prevent the first one?
Also kind of similar is having us take a look at you. And again, if there's certain biomechanical, certain feet are more, can be more prone in some instances. You know, some of those more looking at the foot type, and again, making sure shoes are appropriate, making sure people are training appropriately. Most of these times people are training for something and they're increasing too quickly. But the other thing is if their shoes are getting worn out, they're not properly supported, those are the things that are going to bring those on.
Erin, what's your standard approach as far as diabetic patients if they do not have symptoms of peripheral vascular disease, and if they do not have the signs or symptoms of a diabetic polyneuropathy? What's your recommended screening? Is it yearly? Do you wait till they have diabetes for 5 or 10 years? What's the recommended approach?
You know, sometimes there's a very wide range, so protocol kind of goes per patient, but there's the patient that becomes, for me, that's very uncontrolled. The ones that aren't getting their A1Cs at a reasonable, they're at higher risk for infections, amputations. Those ones need to be seen more often, whether it's 3 months, 6 months, depends on what problems they have. You know, do they have calluses? Do they have these higher risk things that are usually what the problem stems from? A lot of times when people are initially diagnosed, you guys are usually good about sending the patient in, and we do an initial eval, kind of look at the patient's control, look at their risk factors. And those patients that are lower risk, yes, a lot of times it's more of an annual basis. Some that are really proactive about, hey, I've gotten this under control, I'm doing well, I have no vascular, no neuropathy. Sometimes they go more as needed, but those higher risk patients are the ones that we typically need to see more often. Those ones that we've previously done surgery on, we've done previous INDs or amputations, those ones are at higher risk for more problems down the road. So typically I will see them at least initially after surgery for about 3 months, every 3 months, until I'm either comfortable and then spread it out a little bit, or they're always on that 3-month schedule. So patient specific, but that's more or less where I go with it.
Yeah, thanks for the excellent talks. For back to a stress fracture, either the lower leg or the foot, we see them and it's fairly acute and the x-ray is negative. Waiting a couple weeks with much less activity, and then get another x-ray if it's negative, and then a CT scan, or what would your process
If
do?
you have a high index of suspicion, you start treating that day. If you wait, it can be a displaced fracture by the time they come back in 2 weeks later. And in some patients that are like, well, they said it's not broken, so I'm going to do whatever I want type thing. Sometimes they take that to the extreme, even though it hurts them. So if you have a high index of suspicion, it looks like, kind of looks like, smells like, probably is type thing, they need to be immobilized that day. And again, post-op shoes generally are not enough. You got to get them in a boot. Some patients that need more support, we will sometimes cast them, but you got to start treating that day. Otherwise, you can have a little worse outcome.
And then in 2 weeks, if they're still having some pain and a negative x-ray, go to a CT?
I'm going to take a look at them and decide if it still looks like a stress fracture. I'm still treating them like a stress fracture. A lot of times, if it hasn't shown up, sometimes it's a compliance issue that they're not wearing a boot, which is a lot of times why they get a cast as well, because they're not wearing it. You'll ask a patient, "Are you wearing this boot?" Well, not at home. And so, again, you're going to have those things of asking that very specific question to get why it's not working out. But no, I don't always, it's very situational, but the CT is going to be less helpful for a stress fracture. So usually I go on clinical exam. If I'm still confident, I'm still going to be treating it that way. And that's the important part too, of not kind of throwing in the towel and be like, well, it's fine, because again, those can be the late ones that I was showing that take time to show up.
Thank you for the excellent talk. With a negative x-ray and you're considering a stress fracture, do you know, does insurance pay for a boot if we've just got the diagnosis of foot pain or foot sprain, or we don't know for sure it's a stress fracture?
Insurances don't always cover boots anyway. So it doesn't, from my standpoint, I haven't noticed that it's a diagnosis related. I mean, if you have pain, it's reason to use a boot. But sometimes that falls under the durable medical equipment, so it doesn't really matter the diagnosis. I think that's a little insurance dependent. I don't know if I can answer that thoroughly, but it wouldn't change, I guess, diagnosis for them to pay for it in my. All right. Thank you very much.